Okay.
Assalamu alaikum. The short clinical day. First scenario, Mr. William is 45 years old, male. He's presented with abdominal discomfort. Please examine his abdomen. Yes, here you go.
Hello.
Hi, hello.
I'm Dr. Ahmed. I'm doctor in the clinic today. Can I confirm your name and age, please?
No, I'm William. I'm 45.
Uh, Today we are here to discuss some issue related to your health condition and examine you. Is it okay with you?
Yeah, of course, please.
Okay. Okay. I will examine. If you feel any pain or discomfort, please let me know.
Yeah, of course. Yeah.
Okay. I will take two step back to see for any surrounding near to the patient, any medication, any oxygen
Nothing in the
cylinder.
surrounding. No.
Okay. Okay. Then I will examine. I will start my examination hand for any clubbing,
No clapping.
any leukonychia, whitish of
Mm,
the nail.
no leukonychia.
Okay. Any palmar erythema,
No pulmonary erythema.
any doctrine contraction,
No diaphragm contracture.
any deformity in the hand.
No noticeable deformity in the hand.
Okay. I will examine um, JVB.
GVB is not raised. Normal A
Okay.
wave. Yeah.
Okay. I will examine also eye for any color jaundice.
So when you see the eye, yeah. This is the image. So when you see the eye, the patient in the does have one eyelid that is closed. When you open the eyelid, you can zoom in. Are you able to?
Mm,
So there is no obvious pallor in the eye, but
okay.
this is
No
how the
color.
eye
Yes.
looks like. Are you able to see the photo?
Yes. Yes. No, I can see
Yeah.
that. No. Okay. No, I didn't notice any. Okay. I will proceed. Any jaundice?
No obvious jaundice.
Okay. I will check the mouse for any central cyanosis, for any gingival
Mm,
hyperplasia, for
there is
mouse
gingival
hygiene.
hyperplasia. There is gingival hyperplasia.
Gingival hyperplasia. Okay. Any, what about mouse hygiene?
And it's good, not bad.
Okay. Okay. Then, uh, I will check also vital sign, pulse and blood pressure. Then I will,
Pulse and blood pressure is on the higher
okay.
side. Pulse is regular.
Okay. Then I will examine for any gynecomastia, any spider nevi in the case.
There is no gynecomastia or spider nevi, or no.
I will
There
check.
is no stigmata of chronic liver disease.
Okay. Normal axillary hair. Okay. Then I will go back to the end of the bed. I will press leg for any. I will ask the patient, is there any pain? I will check for. Can I brace for lower limb edema?
You are checking for the abdomen or for the legs? I'm sorry.
No, now at the end of the bed
Bed at the
for
end of
leg
the bed.
edema.
There is no
Yes,
lower
for
limb
leg
edema.
edema.
No, there is no
Okay,
lower limb
then
edema.
from same side at the end of the bed, I will ask the patient, can you give me cough?
Cuff normal. There is no obvious
No,
hernia or
no
anything.
hernia. Okay. Can you take deep breath in and out?
Yeah, it's fine.
No, no superficial mass.
No superficial mass.
Okay. No
Are you able to
scar.
see the third photo?
There is another photo. Okay, I will
Yeah.
check. Okay. Yes, I can see. Okay, okay, okay. Then I will no, there is a scar in the right iliac fossa. Okay.
Yes.
No other in there is a small scar also. Okay. Then I will flat the bed. I will kneeling down for superficial palpation, my eye to eye of the patient to check for any tenderness for any superficial masses.
There is no superficial tenderness or Nothing on the superficial and the deep palpation.
Deep palpation, no organomegaly?
No, 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 no. The superficial and deep for the pain, and then you are checking for organomegaly, yeah?
Yes, superficial also for pain and for any masses. Sometimes even if there is mass, can show in the superficial palpation.
There is
No masses.
no masses on the superficial palpation.
Okay, okay. Then I will go to deep palpation for
What you are
organomegaly.
palpating for?
I will check for liver, spleen, and also I will check
Liver,
for
spleen,
kidney.
and okay. For
Okay,
the
I want to
kidney,
do bilateral.
there
I
is
will
for
cover
the
both kidneys.
bilateral ballotment. For the
Yeah.
there is ballotable kidneys,
Palatable kidney. Both side?
both sides.
Okay, okay. Uh, by deep palpation on this scar, is there any mass overlying this scar?
Underlying this
One
scar, there
minute.
is a firm mass.
Huh?
There is a firm mass underlying this scar. Beneath this
Okay,
scar,
smooth surface,
there is a
not
mass.
tender. Okay, not
And
Non-tender
tender.
one
now.
minute left, okay?
Okay, okay, okay. Then I will do also percussion for any shifting dullness. I will do auscultation.
No shifting dullness. Auscultation
Okay,
is
then
normal, no bruit.
okay, good. I will ask the patient, please can you sit down? I will check for
Sitting.
any, yes,
Mhm.
sitting for any basal crepitation, for any sacral edema.
No basal crepitation or sacral edema.
Okay. Uh, uh, I will cover the patient. I will send the patient.
Okay, thank you.
If there is
Anything
time,
else?
if yes, if there is time, I will check also flapping tremor for the hand.
There is some tremor.
Okay,
There
perfect.
is
Thank you. Thank
okay.
you, Dr. Salma.
Thank you.
Examiner question, Dr. Omar.
Can you please present your finding?
Okay, I have examined 45-year-old this gentleman, uh, which is present by a scar in the right iliac fossa with
Mm-hmm.
the mass beneath this scar,
Mm-hmm.
which is a smooth surface, non-tender. Uh,
Mm-hmm.
should be should I check the same size also? Then 4 by 5 or 4 by 2 centimeter.
Mm-hmm.
Then uh, 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 no organomegaly apart
Yes.
from palatable kidney in both bilaterally. There is
Mm-hmm.
also tremor, flapping tremor, uh, in the presence of also gingival hypertrophy and
Mm-hmm.
also slightly raised blood pressure.
Mm-hmm.
And also, I want to complete my examination, and really, this is very, very important. Should I check for fistula? For fistula, this is very important. I didn't do it.
Okay.
Then, my summary to my findings. This is the right iliac fossa scar with the beneath mass, most likely. This is the renal transplant. Most likely, this is my differential. This is the scar of renal transplant, and this is mass transplanted kidney.
What would be the reason, the possible reason for him having a transplant in this case, Dr.
Okay,
Ahmed?
okay. By examination, most likely, as the bilateral kidney is palatable, maybe because of polycystic kidney, most likely because both sides
Mm-hmm.
palatable. Then there is also uh, sign of side effect of the medication, immunosuppression in a form of gingival hypertrophy, and also there is there is raised blood pressure, and also
Any other positive finding in this gentleman?
uh, other positive finding. Uh, I didn't check for fistula. Should I check for fistula? It is functioning or no? Because this is maybe is to check this function. This is transplant is functioning or not functioning by checking for fistula or any new central line.
There is fistula, but there is no recent needling.
Okay, functioning fistula is not recently used.
Mhm.
Okay,
So,
so
is there any other finding you find in this gentleman?
also there is flapping tremor, so I can appreciate also sign of uremia and I could not appreciate any sign of fluid overload.
Okay. If there is time, can I ask one more question, Dr. Bassem?
Yes,
There
still
is.
Yes,
45
yes, yes.
seconds.
Oh, okay. Have you if you had a chance to examine this gentleman again, what else you are checking for in the general examination? What
Sorry,
would
can
be
you
you
repeat your question? Sorry.
if you do have another chance to examine this gentleman? Is there anything that you would like to look for? Hello, can you hear me?
Yes, we can hear you.
Yes, I can hear you.
Yeah.
Uh, other, you mean other examination?
In his general examination.
Uh,
It's fine. We
uh,
will we will
only should I check for recent, recent mode of uh, um, I should I check for previous mode of dialysis and
No, no,
recently, and what you mean
there's no. It's in his general examination when you are
in
examining
examination?
him in general examination, but it's fine.
Okay.
Any other positive finding you noted in this gentleman?
You mean okay for eyes? Yes, for
Okay.
eyes. Yes, yes.
What do you think
I
about his eyes?
um, mm, look like there is ring or this not ring?
No, no, there is no
I
ring,
don't know.
but no, no,
I don't
there
know
is no
والله.
ring, but what is the very obvious before you are examining his eye, before you opened his eyelid, what was the position of his eyelid?
It's dropping.
Okay.
Yes,
And when you elevated his eyelid, what did you find on his left eye? When you are
mm,
checking for anemia,
mm. Yes. No color, but I didn't
there is
get
no
this
pallor,
sign.
yeah.
Yes, and
Do you
even
think
no
that
jaundice.
the direction of the eye is normal
Ah, okay. You mean for direction? Okay.
and the
Is
pupil?
pupil is little dilated
Yes,
downward and outward. Maybe this is third nerve pulse.
yes.
Okay, okay.
We will talk about this. You've got it right, but you should. Shall we start commenting, Dr. Basim, or
Yes,
do
the
you?
time to comment. Yes, 6 minutes already for the examination.
Yeah, yeah. Really
Okay,
well done,
start.
Dr. Salma. You've done so well. It's just these days they are when they are bringing a renal transplant, they bring it with something else. It's linked to the renal transplant. For whatever it could be, possibly for whatever reason, but this gentleman did have a renal transplant due to autosomal dominant polycystic kidney disease. But I would like to ask you, putting all of this again together without the pressure of presenting, I'm sure that you will be able to link the signs. So why do you think that this gentleman did have this presentation in the eye?
I don't know. Relation between third nerve pulse and uh,
Okay. So what do you
renal.
know about autosomal dominant polycystic kidney disease?
Um, um, autosomal dominant polycystic kidney disease.
How the
Yes,
patient
can
usually
yes. Can there is many association with the polycystic kidney disease like mitral valve prolapse and also subarachnoid
Mhm.
hemorrhage. You mean due to
Yeah,
aneurysm? There is
yes,
aneurysm.
yes.
Ah, okay.
So
This is
usually he had an old
okay.
aneurysm and for which he
Mm-mm.
had surgery, but it left him with third cranial nerve palsy And whenever you elevate the eye and you see the pupil is dilated, this was a sign that the parasympathetic fiber on the periphery of the third cranial nerve was compressed. They call it surgical third cranial nerve palsy all the time. This is a clincher usually. They tend to put but what you've really missed, Dr. Selma, in this case, which I didn't expect you to miss it, to be honest, is checking for lymph nodes. So in identifying or examining the physical signs, you have taken the full mark, but in identifying the finding. But for physical examination, the examining the lymph node is really
Yes,
important in this particular
yes,
renal transplant case. Don't ever
yes, yes,
miss
for
the
an
lymph
infection, yes,
nodes. No, no,
yes.
no. Not only for that. You need to check for the neck for two scars. And if the patient is
Yes,
old,
yes. This is, I forgot it for
the
fistula and
scar.
for scar of previous access of dialysis.
No, no, no. This is not only. There is a scar
Okay,
of lymph node resection in the neck, or lymph node mediastinal lymph node sampling, which is a suprasternal notch scar. It's an old technique before. Usually, you will see it in old patients, not a young
okay.
patient. Okay, so there is three things that you should put in your mind when you're examining a neck
This
of
is
a
for
renal
what?
transplant
For
patient.
lymph node?
Yeah, so patient on renal transplant, he is on immunosuppressant. One of the side effects of the immunosuppressant, what is the side effect of the immunosuppressant? Diabetes, and tremors, gingival hyperplasia. But the other possible complications are lymphoproliferative disease, like non-Hodgkin lymphoma. So
Yes.
sometimes they will be having a transverse scar on the lateral aspect of the triangle of the neck, resembling excisional biopsy, or
Okay,
suprasternal notch scar. It's like a small slit. They used to use this approach in the past to sample the lymph nodes in the mediastinum, but now they having the EBUS, so the endoscopic approach, which is much safer. And but it wasn't old. So those are the things that you should keep looking for. Beside, of course, everyone would keep checking for the scars for the old central line, for renal replacement, etc. Those things are well known. You know what I mean?
yes.
When you are commenting on a renal transplant, what you need to comment on
Uh, Current mode of replacement therapy, previous
no
mode
so
of replacement therapy, and adequacy of replacement therapy,
is the
and
transplant
also sign
working?
of
Yeah.
yes,
So is the
yes,
transplant
and
working? Is there any signs of failure? What's the volumic status of the patient? And
yes.
is there any sign of a recent or old renal transplant? The last thing is the side effect of the immunosuppressant. So there are five
Okay,
things they want you to vomit in the first minute, and then he wants to guide the discussion. Like, this is gentleman who had a renal transplant. From examination, I think that the graft is working. He's eovolemic. There is no signs of overload. There is signs of side effects of immunosuppressant, which is tremor. If you noted that he had finger breaking for the glucose check, is recent diabetes, gingival hyperplasia. There is no organomegaly on my examination, and I think that transplant is working. That's it. And then other positive finding in this case would be third cranial nerve palsy, that implying that he could have a aneurysm in the past, because this gentleman has presented today with abdominal discomfort, which is not new.
okay,
Yeah.
yes, okay. I like
Did
this
you?
deep, deep. deep thinking about.
There's
Yeah.
nowadays the trend that in my exam they brought it with renal transplant with hepatosplenomegaly. So they will never bring renal transplant. If they bring a renal transplant alone, then expect the passing score for this would be really high for this station.
Uh,
But
okay.
the this is the trend that I've noted.
Then
Uh,
what else can come how other than third nerve palsy, hepatosplenomegaly?
I
Then
don't know. But it will be something related to the cause. So you might.
uh,
Um, uh, um,
okay,
so
okay, okay.
this is
May come
what it
also by
came.
mitral valve prolapse.
But it's something that you would feel in the abdominal station, like it would be abdominal station. Think that yeah,
Okay, yes,
signs of lymph node excision. Okay,
okay,
scars under his arm, scar in the neck, the two scars that the old scars, splenomegaly as a part of
okay,
lymphoproliferative. Lymphadenopathy would be you
okay,
shouldn't miss lymph node examination in transplant station, whether it's
okay,
Mercedes-Benz shape liver transplant or renal transplant. Always check for lymph nodes
okay, okay,
because you are asking the patient from the beginning, can you expose your abdomen and lower down your trousers till the inguinal regions. Take a deep breath. You will see the scar immediately. You know that this is the station. Okay, so put in your
okay,
mind in my general examination, tremors, nail bed, checking for the fingertips for the glucometer use, then check for the fistula, look for the fistula. The fistula can be old and
yes,
redundant. It's not used now, so it will be a scar, just a scar in his arm.
okay.
Yep.
Yeah,
For
regarding
examination of the
differential and
fistula, what's important?
Oh yeah.
Yes, by palpation and by also sculptation and inspection. Inspection for any
the differential, doctor.
needle prick.
Yeah. The differential. Oh, I'm sorry. The differential diagnosis. You give a reasonable differential. We didn't discuss the differential diagnosis for the possible differentials for third cranial nerve palsy. In this case, it would be traumatic, vascular, aneurysmal, and neoplastic. So the compression from outside, which will be vascular and neoplastic, it would be with pupillary dilation. The vascular cause is due to diabetes or hypertension. The pupil will be spared usually. The eye is down and out. Um, yes, Dr. Sarah. Yes, also one of the other presentation is the cushingoid face with a renal transplant, which is one of the side effect.
Side effect
So
of okay.
yeah. So physical examination, I would mark you down for missing the lymph nodes, identifying
Okay.
the physical signs. Um, um Yes, you can, although that I've tried to get it from your mouth to state that this gentleman that have a third cranial palsy, clinical judgment is overall satisfactory, differential diagnosis satisfactory, welfare is maintained. I don't know if Dr. Bassem agrees or disagrees.
Yeah, yeah, I agree with the same judgment. Just I want to remind here, as you said, the lymph nodes. Again, it's
Okay.
good way to remember. Put it in a paper. What you are missing usually, put it in a paper. I said this
Yes.
advice before. Whatever you
Yes.
are missing or forgetting, put it in a paper in your note that I'm usually forgetting to do this step. For example, in the nervous system examination, the clonus. Okay, usually the clonus you are forgetting to do. So I will write it in the note that I am forgetting to do the clonus. And in the abdominal examination, chest, the lymph nodes. For the cardiovascular, for example, aortic regage murmur.
Yes.
You have to read this note before going inside the station. This is the first, and the night before the examination. And usually read it and try to focus in this part whenever you are doing practice. So by this way, you will never forget what you usually miss. But if you continue forgetting, you will continue forgetting till the exam day. So the best way is to write it in a note that I have to do this whenever I am going to do this station. And the last minute to remind yourself before the cardiac and nervous system station, there is 5 minutes. You don't do anything. No scenario. You cannot read anything. So you can write in your paper that I am reminding myself to do the clonus. I am reminding myself in the cardiac session to do the pulse, to check for the harvesting, the things you usually miss. So by this way, you will not forget it again. This is an general advice. Do it for all the station. Okay.
Okay.
Otherwise, yeah. Otherwise, you did the examination steps confident, fluent. But I don't want you to take time to think what to say to the examiner. They will not forget. They will not wait for you. Okay, they will ask
Yes.
the question. They will give you 3 seconds. If you answer, they will listen. If not, they will skip to the next question or the next part of the discussion. So if you don't know, and you will not know that you didn't read it before, you can say, I cannot recall, sir. I don't know, sir. I'm not sure, sir. Because if you will
Okay.
take time to think, he will minus you from this question, and it will take from the next part discussion, and it will be minus again in the other skills. For example, the differential diagnosis. So if you are not sure that you don't know this information, or you don't know it, or you didn't read it before, don't try to think. Tell him, I'm not sure, sir. I cannot recall it now, sir. Then he will jump to the next question. He will give you another opportunity to gain marks from other skills. For example, the differential, the examination, and so on. Okay.
Okay.
Uh,
Okay.
Uh,
one
yes.
one little advice for Dr. Salma. Whenever you are trying to try to break down your presentation into, for example, there is stations where presentation is common, like renal transplant. This is a case of renal transplant because there is a J-shaped scar on the right iliac fossa with a mass palpable. There is signs of old and um, renal replacement therapy, and there is no recent signs of recent renal replacement or recent use of this whatever fistula. There are also signs of um, lim- of uh, uh, immunosuppressant, and then by breaking it into points to your mind, like this is how I should navigate. Whatever I will find, I will put them on those points to say it in 30 seconds, in 45 seconds. This you should try to minimize the word use, if you are like having difficulty in finding or picking the word, because on the day of the exam you will be stressed, so you will you will not be able to
Forget more.
collect all
Yes.
of the not to forget, you will not be able more to collect the words in English. So
Yes.
try to break down the presentation and spend 1 hour 2 hours um, in front of the camera, like on your laptop. See how you look like, record to yourself, see how your body is taking the posture when you are presenting. Are you going to look around, or you are maintaining eye contact? Because the overall confidence is sometimes gives an impression, even though if you are talking, if even though that if your talking is not your best, but your body posture, maintaining eye contact, putting your hands behind your back, and then say minimal words that you are used to say. Okay, renal transplant patient,
Okay.
the transplant is working. I don't think so. Yeah, you know what I mean. Positive
Yes.
findings are X, Y, and Z. There is no signs of recent renal replacement.
Okay.
You know what I
Yes.
mean?
Yeah.
Yes, yes, yes.
Collectively, Dr. Selma, whenever you have transplanted kidney patient, you have to mention four sentences. Okay. The recurrent mode of renal replacement therapy, the previous mode of renal replacement therapy, the volume status, and the immunosuppressant state or complication.
Yes.
Okay. At least you have to mention
Okay.
these in the last presentation. Be sure that you presented these words, okay, or these sentences. So the current mode of renal replacement, the previous mode of renal replacement, and the volume state, and the immunosuppressant complication, and the previous or the original cause of the kidney failure. Like in our case today, the polycystic kidney or adult polycystic kidney disease. The last question I want to add, what are the types of third nerve palsy, Dr. Salma? What are the causes of third nerve palsy, you know?
Can be diabetes.
Okay, give me another term or another
General.
major pathology.
Um, um, as a complication of diabetes. Can
Okay,
be
in another words,
subarachnoid hemorrhage. Yes.
the medical
Another word.
and surgical.
Surgical. Yes. Painful
Okay,
third nerve palsy. This is the surgical.
okay, and what are the difference between the surgical and medical? And give me example of surgical and give me example of medical.
Uh, والله I didn't remember now, Dr. Basim.
Okay, so
I,
yeah, let's summarize it. The
okay.
surgical one, completely compression of the third nerve, including the parasympathetic and sympathetic, or the all fibers, the external and internal. And the parasympathetic usually are the external parts. Okay, whenever you have surgical, means something compressing from outside. So you will lose all the fibers function, including the parasympathetic and the sympathetic. So what do we have? Outward,
Trauma,
downward.
tumor.
Yeah,
Yes.
yeah, this is the cause. But
Outward,
what
downward.
and
Dilated pupil.
perfect. You have to know this and to memorize it by heart. Okay. The second one, the medical. So you will have affection to the internal fibers, which is a sympathetic one, but the parasympathetic will be maintained. So the manifestation will be
Down and out with no
with
pupillary
no
dilation.
perfect, with no mydriasis. Okay.
Which will be hypertension and diabetes, which would cause vasculopathy, because the vessel runs within the third cranial nerve from inside. So
Yeah,
this is why the affection starts from inside.
perfect. So the
You mean
fibers will
for
be affected.
surgical, down out without dilated pupil?
No, the surgical will be all the fibers, including the parasympathetic, which is outside, and you will have all affection, pupils plus the nerve palsy, which is the movement, the muscles affection. I mean the outward, downward deviation of the eyes.
Okay.
Okay, but the medical cause will affect only the internal fibers or the inside part of of the nerve, and the patient will have outward, downward only without pupils affection. Clear? The causes, as Dr. Omar said, the medical will be diabetes or even the mononeuritis multiplex. The nerve will be
Yes.
as autoimmune or affection or whatever the cause of demyelination, whatever the cause of the third nerve palsy. And the surgical cause will be the most common, Dr. Salma.
Um, communicating artery aneurysm.
Yeah, posterior communicating artery
Yes.
aneurysm.
Yes.
Okay.
Yes.
Perfect. Thank you, Dr. Salma. We are done with the first scenario. I will read quickly the comments. ICH, third nerve, Dr. Sarah Nasser, aneurysm, perfect. Surgical nerve palsy, perfect. The hearing aid, it's advanced,
Yes,
really, it's advanced examination to examine for. But I think if any patient will be having hearing aid, you can notice it. I don't think you can miss an aid in the ear. It's obviously appeared.
but in the exam, silly things happens, Dr. Bassem,
Yes,
from
I
the
think
stress.
with the stress you might forget, but you have
Yeah.
to focus. Or maybe the patient will put it on the drawer or beside. Okay, but take care of this part. If you miss it, you might miss the diagnosis. Also, kidney transplant with cushingoid face. Yes, cushingoid, one of the
Yes.
complication of immunosuppressant you have to look for, plus the gingival, plus the finger prick for diabetes, the hypertension, all the things you have to examine. But mononuclear multiplex, perfect. The pupil will be the difference. Dr. Mahjoub, I think, yes. Dr. Tahani, posterior communicating artery aneurysm, perfect. Dilated and surgical, again, please, Dr. Mu'taz. Diabetes vasculitis. What you want to repeat, Dr. Mu'taz?
I think
Okay,
the
in
causes of
summary.
the
Yeah,
the the, the third
in
kidney.
summary. Yeah, in summary. Remember, the surgical mean, or you can remind yourself like surgical, complete cut of the nerve. Okay, complete cut, so it will cut everything because it's surgical cause. It's not a cut, it's mainly compression, but the compression usually affect the all fibers. So the all fibers will be lost, the function will be lost, including the parasympathetic, which is responsible for the pupil dilation or constriction. So the loss of function will give you dilation, which is mydriasis. So you will have outward downward deviation plus mydriasis. While the medical cause, you don't have complete compression. You just have vasculopathy or affection to the internal fibers because of the impaired blood flow, whatever the cause, diabetes or the nerve affection because of the autoimmune demyelination. So you will have only affection to the movement of the eyes, which is outward downward deviation without any pupil dilatation. I hope it's clear. Now we
Yeah.
can
Uh,
start.
One last question to Dr. Salma is about in the ADPKD. Do you expect that the patient does have nephrectomy before the renal transplant or not in this patient?
Yeah. What? Nephrectomy?
Um, like before the renal transplant in autosomal dominant
Mm.
polycystic kidney disease, is it frequent
Mm.
to remove the
Yes, to
kidney
make
before
room.
the
Yes, yes,
transplant or not?
yes. Mostly
My
to make a room for
No, no.
transplant.
My question is it
Mm.
frequently
Mm.
to be done or not?
According to the size, if size is a very big and take big space, is mandatory to take. If no, I think
No,
like this case is
the
both
routine. No,
bilaterally,
yeah,
but
yeah. The routine is that in ADPKD they don't remove the kidney unless they if they want to make a room. That's it. But
yes,
routinely they will keep both kidneys.
yes, yes,
Okay, thank you. It's a nice question, and that's why you have to examine the back, Dr. Salma. Don't forget to examine the back for
yes, for a scar also.
scar of nephrectomy. And I didn't hear you putting the patient flat.
No, no. She put the
She
patient
put,
flat.
okay.
Yeah, yeah,
It's
yeah. I give
important
her
step.
a like when she put the patient flat.
Yeah,
Flat.
perfect. Anyone or any candidate will not put the patient flat. They might fail them in the all station, whatever the performance is. Okay, like you are doing the wrong technique totally, and the all finding will be made up. So they will not respect whatever you do unless you put the patient flat. Dr. Hosni asking what meant by current mode of renal replacement therapy in renal transplant. Current mode means that yes, it might be functioning renal transplant. However, it might be also rejected, and the current mode will be switched again to the AV fistula or a catheter. So you have to know what's the current mode. Is it kidney or the transplanted kidney functioning well by the mean of no tenderness, the urine output will be okay, and no signs of volume overload. So the new kidney is functioning. In the other arm, if you have tender kidney or transplanted kidney plus catheter or AV fistula, which is having needle marking, or it's having uh, the thrill and the needling is there, mean that the kidney or transplanted kidney is failed or rejected or whatever. And now they are using the technique of AV fistula, for example, or the catheter if you have the catheter in his neck. Okay, so you have to mention what is the current and what is the previous. Okay, thank you, Dr. Hasni. Dr. Omar, your case. 35 years old man present with short of breath. Examine the cardiovascular.
Okay, shall we start?
Yeah, here you go.
Hi, hello, my name is Omar. I'm here to examine your
Hello.
heart. Hi. Can I know just your name? Can I confirm your name and age, please?
I am Ahmed. I'm
35?
35-year old.
Yeah.
Yes, 35-year old.
Yeah. Thank you. I'm here to examine your heart. If you don't mind, if you are not short of breath at the moment, is it okay for me to proceed?
Yes, okay, doctor.
Okay. I'll be looking, listening, and feeling for your heart. Also, checking your arms and your legs, and listening to your back. Okay.
Okay.
Okay, I'll start from the bedside. I'll ask the patient to expose the chest and the abdomen, and asking the patient to take a deep breath and to give me a cuff, and then starting my general examination by asking the patient to outstretch his hands, looking for any signs of clubbing, any signs of any ocular nodule, Janway nodule, and then checking for the pulse equally on both sides, and the pulse character
Doctor,
look,
pulse is
yeah,
irregular.
irregular,
Pulse irregular. Yes. No
irregular.
stigmata of infective endocarditis, but pulse is
Thank you.
irregular. Yes.
Okay, and now I'm checking for water hammer pulse by raising the hand. You don't have
No,
any shoulder pain. Oh,
no, no, doctor.
no, no. So I
Yes.
will be raising your hand above your head. Let me
Yes.
take the weight of your
Not
arm.
collapsing.
No collapsing
Okay.
pulse. Thank you. I will check also for the JVP and
Okay.
hepatojugular reflux. Is there
It's
any
raised, doctor.
raised
GVP is raised.
JVP? Do you have
Yes.
any tenderness in your right upper quadrant, in your around your tummy?
No,
No
no, doctor.
tenderness. When I press, is
Yes.
there any tenderness?
No, no, doctor.
No. Okay. Thank you. Then I will check for the eye for signs of anemia and the oral cavity for any obvious signs. Anything?
No, normal, boss.
Normal.
Eyes and
Now
nose.
I'll
Yes.
palpate for the apex,
Okay.
and then for the P2 and A2, and
Apex is placed outside mid-clavicular line.
outside mid-clavicular line. Okay.
Yes.
And is there any heave or left parasternal heave?
Is resting, doctor, in nature.
Thrusting apex, but
Yes.
the left parasternal heave. Is there any left parasternal heave?
No, doctor. No.
No. Okay.
Yes.
Then I'll auscultate on the
Okay.
apex and asking the patient to lie lateral position, take a deep breath in and out and hold, and check for the propagation to the apex if there is any murmur.
Yes, doctor. There is already murmur in the apex, which
In the
is
apex,
pansystolic murmur.
pansystolic murmur radiating to the axilla. Any change
Yes, doctor.
with expiration?
Yes, yes, doctor.
Okay, so it is increasing with expiration.
Yes, doctor.
I'll check for the tricuspid area also. I'll ask the patient to sit up. I'll auscultate the tricuspid and the pulmonary, asking the patient to take a deep breath in and out, to take a deep breath in and hold.
Okay,
Any
normal.
normal. And finally, for the aortic region, For the aortic area, I'll check if there is any murmur.
No.
No murmur on the aortic region, okay. And then I'll auscultate the back to check for if there is any bibasal crepitation and check for any sacral edema and lower limb edema.
Yes. No basal crepitation, but there is little sacral edema and also lower limb edema.
There is lower limb edema to what level?
Yes,
Till the
positive.
till the knee or above the knee,
Above
or
ankle.
it's above ankles. Okay. Is there any scars on
Above
the leg?
ankle.
Any scars in the chest?
No, doctor.
No.
No. Yes.
Uh, and is there any bibasal crepitation or diminished breath sounds?
No, no, doctor.
No. So breath sounds are normal.
Yes,
Okay. Clear lungs. Yeah. Okay.
yes.
I will complete my examination by checking for any radiofemoral delay and full sets of observation.
1 minute left.
Okay.
Okay.
Okay. Do you want to
I
examine
think.
any other thing?
No, it's just the full sets of observation and checking for radiofemoral delay.
Okay.
Yeah. Thank you.
Finish? Finish?
Yeah.
Okay.
Okay, examiner
Let's look at.
questions.
Okay. Uh, can you present your case?
Today I've examined Mr. Ahmed, who has presented with shortness of breath. On my examination, there was an obvious uh, pansystolic murmur, heard the best on the mitral area, propagating to the axilla and accentuated with expiration. There was no peripheral stigmata of infective endocarditis, but there is a picture of raised JVP and bilateral lower limb edema with sacral edema with clear lungs. This is what I found in this gentleman's case.
Okay. Okay. What is your differential, doctor?
For the pansystolic murmur, given the fact that there is irregular pulse noted on my examination, I think there most likely it is mitral valve regurgitation.
Okay.
Other possible differential for pansystolic murmur would be tricuspid
Yes. Okay.
valve
Mention other
regurg.
one differential. Other one
Um,
differential for also systolic murmur.
it would be a VSD, but I would expect it in a younger patient.
Okay. Okay. Good. Uh, okay. Also, what your patient have other than mitral regurgitation?
What? I'm
Complicated
sorry.
by what?
Um,
I mean, what
oh yeah,
what other
there is a
bed?
picture of heart failure. Yeah,
Okay. Yes, that is mean.
yeah,
Yes,
yeah,
heart failure.
yeah, yeah.
And also, in a form of irregular pulse, the patient is
As there
in,
is atrial fibrillation.
yes, atrial
Yeah.
fibrillation, heart failure, mitral regurgitation, complicated by
Mhm.
heart failure. Okay, good. What investigation you want to do for this patient?
So starting from the bedside, lying and standing blood pressure, urinary dip capillary blood glucose, ECG, and chest X-ray. Routine beside the routine labs, I'll send for B&B, and of course, in inpatient echo for this gentleman. If everything came back normal, I would go for CT chest. Um, uh, any other than this?
What
Mhm.
what you will see in chest X-ray? What is your finding in X-ray?
For the checking for cardiomegaly and also the lung fields, if there is any, if the lung fields is clear as it was in my examination, it was clear. I would
Yes.
think
As
also of
general, yes,
right-sided
this patient
heart
is very
failure.
normal.
Yeah.
Yes, Yes, yes. You want to see pulmonary edema in
Yeah.
the lung, chest X-ray, and also on chest X-ray also, left
The
ventricular mass.
cardiomegaly, if there is any cardiomegaly on the chest
Yes,
X-ray. Yeah.
cardiomegaly number one. Yes.
Yeah.
Okay. In echo, what you will see?
I'll check for the regurgitant valve through the mitral and to grade it, checking for eccentricity. If it's present, then we are thinking of severe mitral valve prolapse, which would require
Yes. For
referring this
severity, what you
gentleman
want to see? For severity, what
for
you
the
want to see
severity in the echo or in general.
in the echo?
In the echo, the eccentricity, if there is any eccentric jets on the echo, this would point to significant regurgitation. Also,
Okay.
dilated left atrium, and
The
but
most
of
important
course,
one.
um
You didn't want to check orifice size? Orifice.
for the mitral area, for the valve
Yes.
area, yes, it will be
Yes.
checked. But
Okay.
I
Okay.
think
I will
the
agree.
most important thing is to control the patient AF before attempting an echo to obtain accurate results.
Okay. 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 Do you want to do any other investigation?
In this gentleman, I would, um, uh, if I don't think so that there is
Okay.
anything
Yes,
in
the
my
most
mind, to be
important is
honest.
mentioned already.
Yeah.
Okay. Okay. Good then. Uh, if there is a time, I can ask one question more.
Yes, please.
Okay. Can you tell me how we will treat this
How
patient?
So first of all, this patient does come with heart failure, so I would admit this patient, starting him on, refer him to cardiology, involve cardiology, starting him on IV furosemide infusion if his blood pressure is maintaining, to subside to improve the edema, and then also, this patient needs to be worked up for possible valve transplant based on the investigation finding. Physio and occupational therapist is important to
Yes,
be
valve
involved in
replacement.
this patient.
When you will do valve replacement,
So
indication for surgery.
for mitral regurgitation, presence of atrial fibrillation itself would would indicate
Yes, if no
the
atrial
surgery.
fibrillation.
Without atrial fibrillation, end diastolic volume above 50, ejection
Mhm.
fraction below 50
Yes.
would be also another indication, or if the valvular area is significantly affected.
Okay. Okay. Symptomatic also severe
Uh,
mitral regurgitation.
yeah.
Yes. Okay. What you will give for air?
For now, we need to establish history for since how long the patient is in atrial fibrillation. I would rate control the patient and start anticoagulating him
Yes. Yes.
if he's not
Done.
anticoagulated.
Okay. 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 Thank you.
Okay, thank you, Dr. Salma. You can comment now.
Um, Actually, well done. Very good. But I think you didn't check for the surrounding if there is any oxygen cylinder behind the patient for surrounding. Then also you
Mhm.
didn't check for carotid fluid as a maybe okay not specific for this patient, but this is the routine examination for cardiovascular.
Yeah.
Uh, then otherwise it's okay. Investigation also don't forget to investigate for infective endocarditis. Called infective endocarditis. Urine blood culture.
Mhm.
Okay. Then also cardiac catheterization can be done in this case to exclude coronary other coronary artery disease also,
Yeah, in the
mainly
workup for
preoperatively if
the
the patient
in
will
the
go to
workup, yeah.
surgery. Yes, If
Mm.
patient severe aortic regurgitation and will go mitral regurgitation and will go to surgery, you need to do cardiac catheterization pre-operatively to exclude coronary artery disease. Otherwise, it's okay. Nothing, I think.
Okay, so let's judge
Very good.
on the skills. Physical examination. He did the steps
Yes,
properly,
yes. Did all step.
and he identified the finding.
Yes.
Did he discover the pulse? Because he didn't present it in the presentation.
Uh,
I presented the pulse irregularly irregular. This is why I said.
You mentioned, okay, so
Yeah.
it's four again.
But I
So,
didn't. I presented it on the differential when I was doing the
yeah,
differential.
no, no,
I
yeah.
recapped and then added. Yeah. I
But the
recapped
first
and added
presentation,
it.
you didn't mention the pulse.
Yes.
I remember, so because I wrote what you have to present in the cardiac station in the
Mm-hmm.
comment down. You can see the pulse. You have
Mm-hmm.
to talk about the pulse, the apex beat, the S1, S2, and the
yes.
murmur.
S1, S2 is didn't ask about. Yes.
Yes, so you have to do examination for both
Mm-hmm.
and to mention is it metallic or natural, and the
Mm.
murmur and the radiation and all the description of the murmur you have to talk about, plus the volume status, the signs of heart failure in bracket, and the signs of pulmonary hypertension by checking loud P2 or parasternal heave, and no signs of infective endocarditis at the hands or at the eyes. If you could say,
Mm-hmm.
I would like to examine by fundoscopy. So, whenever you are in cardiac station, be sure that you will present and you will
Mm-hmm.
say all these finding. Okay,
Okay.
don't say
So I would down myself to be honest in the presentation.
yes,
I don't
yes.
I went blank to be honest.
So I will minus
Yeah.
the clinical the identifying. The finding is as borderline.
Mm-hmm.
What else, Dr. Salma? In the
Other,
clinical
it's okay.
judgment,
Very good. But I think you sang the patient, cover the patient at the end. I didn't listen. You sang the
No,
patient, cover the patient.
no, but usually this is what I do in real life. Yeah, I thank the patient, cover the patient, but in the station in online, no, I don't usually verbalize it to be
it's
honest.
okay.
Really? There is mark on this, Dr. Basim, or no need?
Yeah, it's at least show respect to the patient.
Yeah,
Whatever to
Okay.
cover, to thank, it's not a must, but at least show the examiner that you are respecting
yeah,
him, you
yeah.
are thanking him at the end. Okay. And the differential, what do you think about the differential? He gave good differential.
Yes, good, good. Yes,
Okay,
good
and
differential for
the welfare
split,
also.
bus split.
So he will be only minus in the one skill, so it will be 18 out of 20, right?
Yes.
Okay. Anything you want to add in this case?
Mm.
So let's repeat
I think
the differential.
uh, uh,
So it's a case
we can talk
of
about causes of mitral regurgitation as general. Can be acute cause, can be also chronic cause.
mitral rigor.
Yeah, yes, cause of mitral
Yeah.
regurgitation
So
can
it
be
depends in the
endocarditis.
examiner
Question.
discussion. Yeah, and question. If he wants to go through these, he will go, or he
Yes,
will go
because
through the
I think no
investigation.
time for this one. The most important differential investigation and management. But this one, I don't know if we'll go deeply like
No,
this.
no. Some examiner, to be honest, some examiner they want to go through the causes, and others will go through the investigation. Other will go through the management, the differential.
Okay,
So it's
okay,
as overall discussion according to the examiner instruction what he want to go through. For example, if
okay.
you
So
have
for the
young,
causes, yeah,
yeah, for the causes, let's mention
I
them,
will so if it's
but
acute
in
or
a
chronic,
systematic way.
yeah, acute
Perfect.
or
Yeah,
chronic, acute
perfect.
Yes,
would be post
yes,
MI or rupture of sinus of Valsalva. The second one for the chronic would be due to dilated cardiomyopathy or after infective endocarditis or rheumatic fever, rheumatic heart disease, rheumatic fever. Also, in one last thing is the connective tissue disease. Uh, Hello? Yeah. Did I
Yes,
miss
yes.
anything?
I think no. Acute, like also endocarditis, can be the cause of acute.
Yeah,
Yes.
So
so
we need
either
to
to
check
start
for
in this way, either acute or chronic, or to start as a congenital or acquired.
Mm-hmm.
yes,
Okay, some examiner want to hear the congenital cause, and they like to hear it as congenital causes. So, for example, you can have the connective tissue disease, or it can be prolapse due to the like our case today, autosomal or adult polycystic kidney disease, so collagen disease. So they like to hear those things. Then you can see the acquired from the infective endocarditis, traumatic, ischemic, MI, or infection, as we said, the infective endocarditis, or
Infective
rheumatic
endocarditis.
one. Yeah, and rheumatic one. So it depends on your division, whatever you start, but be systematic. Don't say the disease randomly. So don't say
Mm-hmm.
infective endocarditis, rheumatic fever. No, they like to hear as categorized answer, not
Mm-hmm.
as disease wise. Okay.
Mm-hmm.
Yeah, this is
okay,
the way to answer any cause or any pathology. In particular, if you have young female or young male, try to mention the congenital cause first. Okay. For the elderly, don't forget to say the sclerotic. Okay.
But I
okay.
didn't miss any
Or
cause in
degenerative.
the mitral.
Degenerative or sclerotic. Yes, Dr. Omar, what? Again?
I didn't. Did I miss any causes of the mitral valve
No,
in the
no,
causes I said?
but they like to hear, if you mention all this, what I mentioned, they like to hear
Uh,
infective endocarditis and rheumatic heart
Classified.
disease.
Yeah.
Yeah, this is what
Yes,
they and also the post-traumatic, post-MI. They like to hear all this stuff. Okay.
Mhm.
yes. In endocarditis, how you know during short case, we will check the dental
For the
for
stigmata. Yeah.
dietitian, is and stigmata, and also
Yeah,
IV access. IV access. This is can tell us if there is any endocarditis.
Genway
And
lesion
also
and
in
oslar nodes. Yes, you
yes,
have to find
stigmata.
the splinter hemorrhage.
Yes,
What
yes,
Okay.
what I did find that when they discuss the infective endocarditis, they will bring it as a midline sternotomy scar with no harvesting scar in the leg. Likely he is having a prosthetic valve, usually tissue valve or mechanical valve. And they will tell that the patient present with fever and shortness of breath or shortness of breath. Then maybe you can't find the vasculitic picture of the stigmata of the infective
Perfect.
endocarditis, but the discussion would go toward infective
Exactly.
endocarditis.
The examiner will take you to this part of this discussion. He will tell you what
yes,
the doc's criteria, how to investigate, how to manage the surgical intervention, the indication of replacement. All these questions will be taken by the examiner through this part.
yes,
Okay.
yes.
Doctor,
Also, both acute ischemic event can be due to rupture of the papillary muscle.
yes, you have to mention
Yes,
it.
yes.
They like
And
to hear
also
it
other
also.
cause, yes,
Mhm.
other cause in the chronic cause can be degenerative or can be also after valvotomy in case of mitral stenosis. The patient already mitral stenosis, valvotomy was
Yes,
done, then
Yeah,
also mitral
yeah,
valve.
commissurotomy, it's a post correction
Yes,
of mitral stenosis,
yeah,
yes,
perfect.
and the
So
aortic
it can
regurg is
be,
also the same.
yeah, so
yes,
it can be as post procedure or post correction or post valvotomy, as you mentioned.
Hmm.
yeah,
There is a variety, or there are a variety of causes, but you have to mention the most common one. Then you go through the what you mentioned, as you said, but don't forget to say the infective endocarditis again and the rheumatic heart disease. Okay.
yes, yes. This is very important.
Dr. Hasni is asking about the position of the patient. Should be in the recumbent position at the start, sitting or
Chest and
semi-sitting.
abdomen 45, sir.
Yeah. Don't do it in,
Chest and cardio 45.
yeah, yeah. Don't do it in flat or position. Okay, they will minus you, so you cannot judge on it if the patient in the flat position. So it should be in the same setting. And any other comment I miss? Let's go back to the chat box. Nothing. I think it was about the
Dr.
current.
Basim, I have one
Yes,
question. What I will
sure.
do if I didn't find APEX in exam?
If you
Sometimes
didn't
I
find
find
what?
some difficulty in APEX in examination. APEX beat.
Yeah,
Sometimes
there
difficult to
is two
find for me.
methods, either
Yes.
palpation or auscultation, right?
Okay.
If you
Okay. Yeah.
couldn't,
And
you can
if
say,
I
I
didn't find in
couldn't.
palpation,
Yeah,
I
yeah.
use auscultation.
Yes, you can say it. I couldn't palpate it. For example, one of my attempt, it was a female with obese one, and difficult to palpate the pics because of the breast. And I said it honestly, and they didn't minus me in this part. So say what you are honestly feeling, that I couldn't do so because of the obese or because of the breast, whatever. But try to palpate it. If you couldn't, you can say I couldn't palpate it.
Okay.
And I prefer
Hmm.
to say I couldn't rather than made up the finding.
Yes,
Okay.
yes.
Yeah,
Because if
because
I didn't find, I cannot know the character. I cannot know any.
yes, you can do. You can say
So
that.
how I
You
will
can do.
manipulate?
You can say that.
You can say
But
it in
if
a
you,
nice way, like I couldn't appreciate the apex. That's it.
yes, yeah,
Okay.
and if you made up the finding, they might fail you in the old station. But if you say I couldn't feel, they can give you some marks. Okay.
Okay. Even if there, I do it.
Yes, if there is for example,
To, be- to
hepatosplenomegaly. If you
Mhm.
mention, I know one of the candidate. The case was hepatosplenomegaly, and he said I couldn't palpate the liver, but he filled the spleen, and the discussion went through the splenomegaly and blah blah blah, and they give him, I think 14 out of 20, and they wrote in the feedback he couldn't feel the liver. Another
Okay.
candidate, he said to me that the when he examined for the chest, okay, he made up the clubbing. He said there is clubbing, there is I think also something else. Anyway, they gave him 6 out of 20, although the discussion was good. Imagine the difference between
Yes.
someone who
Fine.
made the finding
Ah,
and the other one who said I couldn't find, and he could.
okay.
Okay, so it's better not to make up any finding because it's irritating them.
To be honest, Dr. Bassem, for all cardiology cases that I practiced on, I couldn't appreciate the apex except in two patients. Both are very, very lean patients, and they do have like really, they had he had severe mitral regurg, so his apex was literally jumping out of his chest.
Yeah.
You can see the
Yes,
pulsation,
you can see it. You can see it. This is the difference between, and but to be
but
honest,
the
not
other, I wasn't
exactly.
able to
Yeah.
palpate it, to
Yes,
be honest.
exactly. You will not see it or palpate it unless he's very thin. He doesn't have any fat and no tissue, subcutaneous tissue, so you can see it. We can say if malnourished patient, you can see it. But if any subcutaneous fat, it's very difficult to palpate or to see it. But you have to mention it in your presentation, as I wrote in the chat box, the apex, starting from the pulse, because the first thing to examine is the pulse. So I could find the pulse is regular or irregular, and they like to hear about the pulse because the pulse is the most and the first finding to discover, and it's related directly to the heart. For
Mhm.
example, if the patient is having AF, and if I couldn't say there is AF, what they will give me, or how they can judge on my performance if I couldn't say or if I didn't say about the pulse, because the pulse there was AF or regular or atrial fibrillation. Don't say AF. Try to say the term atrial fibrillation. What I want to say, the pulse is very important, and the window to start of the presentation with is the pulse character, symmetry, the volume, and by the way, not only the pulse as number or character, even the collapsibility, bounding or not bounding, collapsing. You have to specify some words about it. Then you will go to the cardiovascular finding, as I wrote, the apex, the S1, S2, then the signs, the murmur. And the murmur, you have to talk about the murmur in three things, as you know, all of you. Where exactly, the maximum intensity, and the radiation, and even the relation
Intuition.
to respiration.
Yeah.
So the site, the relation to respiration, the maximum intensity, and the radiation. Okay?
Uh, can I ask one question, Dr.
Yeah,
Bassem?
yeah, sure.
I'm asking this question because one of colleagues he had an aortic stenosis in his exam, but he phrased the pulse character incorrectly, so they give him unsatisfactory in this part. He said slow rising pulse when he meant to say small volume pulse or low volume pulse. But to be honest, this area remains vague for me. I wanted to ask how to differentiate in the pulse character. Uh, what's the difference between slow rising and how to check for it and low volume? Low volume
Okay.
is that the pulse is faint, you can't feel it
Yeah, yeah,
properly.
yeah.
But the slow rising,
Slow rising, I think it's in the carotid, not in the radial.
yeah. But how to look for it? Is it to look or to feel? Um,
Slow rising, something to look. You can see it. Slow rising pulse in the carotid.
Upstroking, like.
Yes, exactly. In the neck, not in the. So
Mhm.
you cannot say it in the radial. You can feel it, or you can
Yeah.
see it in the neck. But for the low volume pulse in the radial, you can
Mm-hmm.
feel the pulse is faint.
Mm-hmm.
And this is a character of aortic stenosis, right?
Mm-hmm.
But if you have, for example, our high volume pulse, and you heard aortic stenosis murmur, what do you think?
A good volume pulse, and you hear
Yes,
an
or wide,
aortic stenosis murmur.
yeah, with aortic stenosis murmur, what do you think?
Wide pulse pressure,
Maybe any other hyperdynamic circulation like fever.
Okay, this is a cause, but what you are suspecting in the valve itself?
double
Maybe
lesion,
mixed valve,
like
aortic
Exactly,
regurgitation
yes,
double
mixed
mixed.
lesion.
valve.
Yes,
Yes, mixed valve.
mixed.
Yeah,
Okay.
Mm-hmm.
I know one of the candidate also. It was this finding. So he find the pulse is wide. However, the murmur was carotid stenosis or aortic stenosis radiating to the carotid.
Mm-hmm.
And he mentioned that specifically to the examiner that the pulse is not going with the murmur. And the examiner was wondering why you are saying that. He said supposed to be low volume pulse, but this patient is having collapsing pulse even. So I
Mm,
think there is mixed valve lesion, and he gave him the full mark, 20 out of 20.
yeah.
So whatever you are feeling, say it, and try to be honest. As I said, don't make up the finding. And the pulse, you have to mention it whenever you start the presentation. This is my take-home message today.
Excuse
Okay?
me, Dr. Bassem, if it is a
Yes.
mixed valve lesion,
Yes.
should we hear aortic regurg murmur or only aortic stenosis?
Perfect. So the predominant one, you will hear it. Okay, supposed to hear if it's aortic stenosis, the predominant, so you'll hear the murmur of aortic stenosis, the second or the first aortic area radiating to the carotid, and the pulse volume will be there because of the aortic regurg. But to be honest, the murmur of aortic regurg couldn't be
Very
heard.
difficult.
Yeah, couldn't be heard during his examination, and he didn't mention it as a finding, and he gave him the full mark. I'm not sure it could be there or no, but the predominant there was the aortic stenosis murmur.
I mean, if there is collapsing pulse, this means the aortic regurg is more than stenosis.
Stenosis.
I need expert cardiologist opinion in this part. I don't know.
No, to be
I'm
honest, Dr. Bassem, when I've seen one of the videos, and also Dr. Hasni, when they had the discussion, they said because of the pulse, on past test videos, they said if the pulse is pointing toward aortic regurgitation, then likely this is the dominant lesion.
That's
And
what I mean.
they appreciated. They said sometimes it's difficult to pick the aortic regurg murmur, but you can use it as an excuse if he told you, but if you're able to hear. And there is one patient I've examined yesterday, and he had both murmurs, systolic and diastolic, which is very, very, very few. I didn't expect myself to hear it at all. But he did have regurg, but his pulse was low volume,
yeah.
wasn't collapsing.
So
So
it
this is in this situation. I was discussing this with the cardiology registrar yesterday. He said you can use the pulse to justify your
yeah.
leaning toward aortic stenosis as as the predominant, but if the pulse is on collapsing, you can justify it. This is the it could be the aortic regurgis dominant.
Yeah, also to be honest, the calibration of the case will be according. The discussion will go through the calibration itself. So if they have the dominant aortic stenosis, the discussion will go through the aortic stenosis. If the discussion will go through both, so they will be the case of a dominant or both of them. So the dominant one will be the discussion, or the discussion will be through the dominant part or the dominant pathology. You got my point. So, but you can't say it as a finding, okay? And the collapsing pulse is obviously noticed by everyone. You can do it easily, and every patient, even in your clinic, if you find a patient and you want to do the collapsing pulse, you can notice it or you can feel it easily, okay? And the pulse volume itself, you can do it. It's easy thing to do rather than examining the apex. Compared to the apex, the collapsing or the radial pulse will be easier, I think. Okay, good discussion. Thank you. We'll go to the next point, Doctor. Doctor,
Can, can I have a
indication.
question?
Yeah, sure.
In case of mixed lesion, the treatment will be directed to the dominant one.
Perfect. Yes. So the signs of the dominant one will be the treatment, and indication of surgery will be also dependent on the symptoms. If the aortic stenosis present with syncope, different than those who presented with angina, or different than those who present with heart failure, right? And the age itself, is it in young patient? Is it in elderly? Is it TAVI or is it total replacement? So it depends on the dominant, it depends on the age, it depends on the manifestation or symptoms. And the examiner will go through all this part during the discussion. So let's read this comment. Indication for removal of original kidney. Oh, okay, this is for the first case. Any question else for the
Yes,
second case?
Yes, Dr. Basim, I just want to comment. First of all, thank you for these great sessions. My comment upon just some tips in this examination, identifying the physical signs is very important because you will build all the discussion upon your findings. For example, if you find the signs, then upon the signs you will build up the differential diagnosis, and upon the differential diagnosis you will build up upon the clinical judgment. So if this is affected, the others too it will be affected most probably. So the most important things, if sign not present, don't mention, because they mentioned clearly in the website. If the candidate mentioned something not present, they will give him unsatisfactory. And if you mention signs, you said For example, he has irregular bus and AF atrial fibrillation, and you said he don't have the patient. He doesn't have atrial fibrillation, and you say he has atrial fibrillation, and you make signs which is not present in real. This is
Yeah, this is what we are
unsatisfactory.
saying. It's makeup. They
Yeah,
are saying it as makeup. Yes.
this is number one. Number two, according to the experience of many of our friends, if you are not sure about something, the science, fine or not, better to forget to not mention. Yani
Exactly.
like what you
Yes.
said, slow rising pulse. Unless you just mention what you are confident there is a small
Yes.
pulse.
Exactly.
Forget
Perfect.
about that one because if it's wrong, you will be punished, and if it's you will go in a different area. So give
He misspelled
the
it, Dr. Mahjoub. He
huh?
misphrased.
Yeah,
My colleague, he misphrased. He meant
yeah.
to say low volume pulse, but he said
The,
it's slow rising.
Yeah, I got your
You
points.
know,
And also, you know that because the examiner will know that you detect the signs upon your talk. So your talk he will depend even if you did that by mistake. So if even if you catch the signs during your examination and you did not talk to the examiner that you did not mention that signs, that means you did not got the signs. You got my point? And for example, if you catch the murmur of mitral regel right here, and you did not tell the examiner that I found systolic murmur like this, although you got and between yourself, I catch the murmur, but in stress or something I did not mention that you will get as you did not identify the physical signs. So in order to not forget, it's better to be systematic. يعني for example in cardiovascular Dr. Basim said you will be step by step hands for signs of infective endocarditis, then the pulse, then the JVB, then the cardiovascular for heart sounds, murmur, added sound, just like the steps all we know. And the others, the last point I want to mention, in case of differential diagnosis like here, يعني after you said all your signs, and I prefer to say all your signs, then you will give the most differential diagnosis. Because if you mention all your signs systematic, you will not forget. And if you say the signs, they will give you mark because the identifying fitting in signs is one of the criteria to be assessed. And what I want to the differential diagnosis regarding differential diagnosis for this example mitral pansystolic murmur اللي هو mitral regale. Instead, if the examiner ask about the cause, he will not mention the whole causes about the acute and correct. No, no, no. You have given a specific case, this patient in front of you, based upon your examination. What is your most probable diagnosis based on your age? For example, as Dr. Basim said, if the age is يعني young, not like the old age. The causes, I mean, if you found the stenosis or aortic regale or aortic stenosis, the cause is different according to the age, according to the ischemic, according to the rheumatic heart disease. So you will give your differential diagnosis not upon the what you know about in the books, acute, chronic. No, no, you will give the most differential diagnosis in your case. For example, if you found uh, patient old, maybe the generative cause will be the number one. Then you will mention the others. If he asks you, you will
Perfect.
mention that. Thank you.
Yeah, thank you, Dr. Mahjoub. I want to add also the center, even the center you are doing the exam depends, or you can give differential depends on the center. For example, if you are in Egypt and Middle East, the rheumatoid or the rheumatic fever or the rheumatic heart disease will be in the top of yours. Some also of the poor countries, you can say infective endocarditis. In particular, if you have mediastenotomy scar, you have to mention infective endocarditis on top of your differential. Okay, so it depends on the age, it depends on the center, the epidemiology. So make sense to every differential you are saying. Okay, thank you again, Dr. Mahjoub. The last question in the chat box about first case, I will indication for removal original kidney and when not in case of transplant. So the first part, indication of removal of original kidney, there is multiple indication. in the top of them, whenever you are planning to do the transplant, so to have a room or space for the new kidney, because the old kidney always takes space. So whenever you want to transplant another kidney in the pelvis or whatever the area, you have to remove and to make a space for the new one. This is one of the indication. Other indication,
Chronic
infection,
infection,
exactly, infection, and
tumor,
or
cancer.
tumor, or pain,
Yeah.
recurrent pain. So recurrent pain, recurrent stone, infection, and trauma, for example, as another indication, not in adult polycystic, but the top, in our case, renal transplant as adult polycystic, the most important cause you have or indication to say is the space, to make a room or to make a space for the new kidney. The second part of the question, when not in case of transplant, yeah, I think we mentioned it. When not in case of transplant, as I said, as a trauma. If you have a trauma and that kidney already damaged or teared, so they can remove it. Infection or pyelonephritis, okay.
Mm.
So these are the indication to remove a kidney without transplant. If you mention also the donation itself, this is an indication. It's a smart answer out of the box, but it's one of the indication. If the patient want to donate his kidney and he is fine, so he can remove or they can donate or they can remove it to donate to the other patient who need it as a live donor. Okay. Any question else? Any comments?
No,
What
I
I
think
realized
everything
from
is
the
clear.
short station or the short clinical, it's short one and depends on the simulation. We are not seeing patient, but it had a lot of discussion and which is really it's a helpful, informative one. Although we are doing it one day a week, but still it's one of the preferred one for me. And I think for all of you. Any doubts?
No,
Yes. Okay. Thank you, Dr. Omar, Dr. Salma.
thank you, Dr. Bassem.
We are back to
Thank
Omar
you
and
very
Salma.
much. Thank
Yeah.
you very much,
Thank you.
Dr. Bassem. Have
Yeah.
a nice
Thank
day.
you, Doctor. Thank you, Dr. Mahjoub, and everyone in the session. I hope I don't forget any. See you tomorrow, inshallah, with the long clinical consultation day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
عليكم السلام.